high-flying robotic surgery, I'll come down to laparoscopic gallbladder surgery, which all of us are doing for the last about 20 years, and I try to find out, have we made anything better for the patient and ourselves in this particular area. At the outset, I thank Dr. Mishra and Dr. Chavan for inviting me. It's a wonderful place to come to, and one telephone call from this place, we always would like to come to, however busy we are. And it's nice to be associated with such a wonderful teacher, Dr. Mishra. I've never seen a more wonderful teacher in my lifetime. And we're all blessed to be with him. Chairman, sir, dear friends, I shall be talking about day surgery, laparoscopic surgery, next couple of minutes. Day surgery, by and large, by definition, is any surgery and hospital stay less than 24 hours. By and large, most places, a 23-hour stay is what is called day surgery, and patient will be admitted this morning, this afternoon, getting operated, and getting discharged tomorrow morning. Even overnight stay also come into that category. Now, I bring greetings from this center. This is Apollo Day Surgery. Actually, although there are a chain of centers in India which are short stay surgery centers, which are 3-day stay, stand-alone day surgery center is the only one I know of, and that is Apollo Day Surgery Center. The shutters open at 5 o'clock and close at 7 o'clock. Now, even today, there are, in our hospital where I work, there are some very senior surgeons who are not accustomed to lap surgery, try to make the patients believe in open cholecystectomy. And still patients, some of them think that, okay, we'll undergo, because they are not, the surgeons are not exposed to laparoscopy, and they'll talk all in favor of open surgery. In addition to that, across the country, there is a tremendous variation in hospital stay. There are surgeons who will discharge overnight, and there are some who can keep from 2 to 4 nights stay. And there are also places in India where patients will be over 2 to 3 days. I have seen surgeons in my own hospital that routinely put drains in all cases of laparoscopic cholecystectomy. Less than 24 hours stay in India is still anecdotal. And why is it so? Because surgeons want to play safe, because biliary system, however simple it may be, when it lands in trouble, which is quite likely, it will be disastrous. You don't want the patient to go home and get in trouble, go elsewhere. Patients are not aware that laparoscopic surgery, gallbladder surgery can be done as day surgery. More than that, the biggest bugbear is insurance companies in India. They don't finance day surgery, laparoscopic surgery. Actually, when I started, you'll have to believe that 70% of the laparoscopic gallbladder surgery in the Western world is done as day surgery. 70%. In India, it will be less, single digits or even less. When I started doing it as day surgery, our administration called me and said, laparoscopic gallbladder surgery doesn't come under day surgery, so it can't be put under that. Then I started doing diagnostic laparoscopy and proceed, and I did it. When they found out, they were very angry with it, so we cannot do. Then subsequently, our chairman, Dr. P.C. Reddy, saw in the United States, all big hospitals had an attached day surgery center, and day surgery center, the laparoscopic surgery is done quite often. Then he said, why are we not doing? That's when I was called, it's no, we have a separate center built up and start doing it. Then I just gathered a team, and then it started working. Then the biggest advantage, the biggest advancement that happened in our team was the transverse abdominal plane block, the anesthetic block, which made this surgery absolutely pain-free. Now with that, we realized that we can progressively reduce the hospital stay to less than 6 hours for laparoscopic gallbladder surgery. That's how I titled it ultra short stay laparoscopic cholecystectomy, not laparoscopic day surgery. Now, how do we go about these patients? We have an outpatient consultation as we see these patients. This patient with symptomatic gallstones, and we have a preoperative investigation checklist to make sure everything is all right, the bile duct is all right, no there is any obstruction. Our anesthetist also sees the patient the day we see them, and the ones we exclude for day surgery are the ones with poor cardiac risk, uncontrolled hypothyroidism, coagulopathy, and there are evidence of gangrenous cholecystitis and a vague suspicion that this patient may be harboring a cancer gallbladder. These are the ones we don't take up a day surgery. And then how do you do? The biggest secret of doing daycare laparoscopic gallbladder surgery is scheduling early in the morning. Every day, In the last about 3 years, I wake up at 5 o'clock and 5:30 I'm in the operation theatre. To make this happen, 15 people wake up at 4 o'clock and make this happen. Early morning scheduling, we have a standard anesthetic protocol. Our anesthesia is bilateral, subcostal and tab block, about which I will tell a little more in detail. We give this tab block pre-incision. I will also tell you what it means. We use a supraumbilical varus needle, palmar point, if there's any scars in the umbilical area. Standard 4-port technique. I use only monopolar, Maryland, I don't use, and hook, I don't use harmonic. Many surgeons I've seen use harmonic for gallbladder surgery, not necessary. I never put drains, unless and it is absolutely necessary. Now this is how the tab block is done, ultrasound guided, with a, where you can make out the layers to the abdominal wall. This is done after a general anesthetic. Now the biggest thing is we explain these patients that your surgery is going to daycare surgery, afternoon you will be home. We try to convince them. If you don't tell them, they say, well, we'll not go, we'll stay overnight. And that's how you can see the various layers of the abdominal wall, and between the transverse abdominis muscle and the peritoneum, the anesthetic is injected. And this is, if you see some scars here in this area, this is a patient who had laparoscopic surgery and subsequently tab block is given. This is post-incision. We stopped doing this, we started doing pre-incision. I'll tell you why. Now, the general anesthesia, this is the protocol, because anesthesia makes a difference, all the difference in daycare laparoscopic gallbladder surgery. Induction is propofol, muscle relaxation, articulum, orogastric tube only for a short while, endotracheal intubation, all that, and then we will give a multimodal analgesia, includes IV fentanyl, diclofenac infusion, and all these patients get suppository as well. And of course, subsequent to surgery, we give paracetamol 1 gram as infusion. And we also give IV dexamethasone 8 milligram induction, and this prevents, this along with ondansetron prevents postoperative vomiting. It's a major concern in any of these patients who have GA for surgery. Now, those are the ports, conventional ports, and the medication to use for local anesthetic is 0.125% bupivacaine, 20 ml each side, and that is not only bilateral subcostal, bilateral tab block, all these 4 places the injections are given. And I told you we give a pre-incision tab block, that is before we make any nick on the abdomen. Now actually this particular tab block paper by our anesthetist has won the best paper award in the annual conference of Indian Association of Ambulatory Surgery in Bangalore 2013. Now, with these patients, we put a Rylsub at the time of surgery and take it off after the surgery is over. Oral liquids within 3 hours, and these patients are closely monitored in the recovery ward by a well-trained recovery staff. Everyone from the doorkeeper to the liftman knows that this is a day surgery center. Anybody who comes in goes off. Nobody stays there. So they all are tuned to that, and they all make sure that patient gets up early, walks early, drinks early, and so on. Now, this patient is frequently visited by our anesthetist in-house, and we maintain a pain score chart, the visual analog score chart, which starts from the time of post-op recovery till the patient sees us 24 hours later. This is a nurse-mediated discharge. There is no doctor at the time of discharge. The day surgery, we don't have a surgeon. I operate for about 3 hours in the morning, day surgery, go off to our main hospital. We start off our esophagus, this, that, and we also do robotic surgery. Now, actually, I'm one of the first students trained under Dr. Mishra in this institution. I'm very proud to say that. I learned my basics of robotic surgery here. And then after the patient passes urine, patient goes home. He walks to the ambulance. Patient doesn't take a wheelchair or anything like that. Patient walks to the ambulance. The patient is dropped at his hotel, because majority of the patients we see are in northern eastern India, and they stay in a hotel, not at home. They have light meal in the night, normal breakfast the following morning, and usually our nurse will come somewhere in the night, late night, brings up the patient to find out if everything is all right, and the patients visit me the following morning. The thing that intrigued me the most is, I couldn't make out who's the patient, who's the attendant. Patient is fresh, with lipstick and all that, just normal. Patient attendant is all tired, keeping a watch on the patient through the night. I wondered, how was this happening? Why is it that this didn't happen all these days? When I admit a patient and keep overnight, next morning the patient doesn't get up. They say, can I turn this side? They say, can I turn that side? And doctor, I'm not feeling hungry. I'll stay for one more day and go. But when we have patients, daycare surgery, they're just fine. You'll not believe, I wanted to shoot a video on one patient from Calcutta. Then I said, where were you last night? I said, I went to the Marina Beach. When he got discharged at 2 o'clock, I didn't believe that. That is the advantage of day surgery as well as this tab block. Now, they travel back home the same day, they see me in the OPD. They have a shower in the morning because the opsites we apply are waterproof. And then there are no skin sutures, there are no issue. They're coming back for suture removal. They're given oral analgesics for 3 days. Between November 2011 and January 2014, I had operated about 350 cases of daycare lap cholecystectomy, which included 32 cases of acute cholecystitis. I thought the acute cholecystitis would be difficult, but once you are into it, it's not that difficult. 44 patients are post-ERCP. They have ERCP today, lap chole tomorrow. Completion cholecystectomy. Patient had underwent cholecystectomy elsewhere. Remnant gallbladder, remnant stones. That we did 4. Completion cholecystectomy, a patient with situs inversus totalis. Patient gallbladder this side had cholecystectomy, some remnant remained. That also we had one patient, we did as day surgery. Lap chole with hernia repair 3. 2 patients we had to keep drains, and among 358, and these 2 patients the drain is removed the following day. Now mean duration of surgery is 65 minutes. Of that 20 odd minutes, 25 minutes is tab block itself, because our NSS is very clear, they clean it and then they'll get everything in position to make sure that is done, and the rest of surgery. Mean duration of hospital stay is 5.6 hours, believe me. Total time over liquids 3.5 hours, total time to ambulance 3.6 hours, time to pass urine is this. Pain score, only in the pain score is 0 to 3 in 95% of the patients. I have enough of this follow-up sheets, 0 out of 10, 0 out of 10, 0 out of 10, completely all through 24 hours. I was surprised. 0 out of 10 is as good as us. For that we have 1 by 10 sitting on these chairs. Listening to lecture will be 2 by 10. Right? Significant post-operative nausea vomiting is less than 5% patients. That is because of the ondansetron and the dexamethasone. They never have ever come, nobody ever rang up or told us that they had nausea. Now this is a difference between pre-incision, post-incision. The problem is when patient has incision, laparoscopic gallbladder surgery over, then go for tab block, because sometimes the air may get into the abdominal wall, we can't make out the planes properly. That will get distorted. Anesthetist said, please don't do surgery and then give us before surgery, we have all the planes proper, you distort the planes. And that create a lot of difference, and we could discharge patients in less than 5 hours, the number of them when we shifted over to that. You should believe these statistics. We presented this in Budapest, Hungary, in the International Ambulatory Surgery. When I said hospital readmission is 0, they didn't believe. If you believe me, not even one patient out of 358 came back to the hospital in that night saying they had an issue. None of them came back or rang up or they said any issue regarding it, that some swelling was there. Then we wondered possibly the needle could have injured the inferior epigastric or one of his branches, and then we aspirated the patient become all right. The other one, my anesthetist said, no, it's not related to our tab block, it is maybe related to your trocar side. I said, trocar is somewhere far away from the inferior epigastric artery, unlikely, but then they still maintain it that it may not be. But that's one complication we've seen out of 358. We had one patient with sort of florid umbilical sepsis. Immediately, it is not that atypical mycobacterial infection, that settled down with antibiotics. And other than that, we had no other morbidity. Is screen coming?
Yes, that's coming.
Now, we thought, okay, if gallbladder is that comfortable, why shouldn't we translate to other surgeries? Then we have done so many other laparoscopic surgeries under daycare, and then we've done 41 groin hernias, 10 lap ventral hernias, lap appendix 3, lap epiculasis. We did lap fundoplication, 4 patients, hydatid 3, rectopexy 2, lap others 7. And even these patients, the mean hospital stay is less than 6 hours. And we have wondered that why is that these surgeries are not done as day surgery all over the country all these years. So, ladies and gentlemen, in summary, ultra short stay, not a daycare surgery, less than 6 hour hospital stay, lap call is feasible. If you properly select cases preoperatively, have a very good anesthesia team, good pre-anesthetic check. Patient should be told that, see, this is a day surgery. It's like outpatient. You come in the morning, you don't get hospitalized, no admission, you get the surgery done. Afternoon, you walk back home. It's much shorter than you're coming and seeing me in the outpatient. When we follow standard anesthetic protocol, very standard surgical technique, and a very standard post-op regimen, this ultra-short cell abscopectomy is possible. And all that you require is a dedicated facility which we have in the form of Apollo day surgery that is only tuned completely for day surgery. No patient can be hospitalized overnight there, and a committed nursing and paramedical team. And also I take this opportunity to invite you all to Indian Association of Day Surgery annual conference which I am conducting in 2014, April 18-19 in Chennai. That's where we have the British Association of Day Surgery chairpersons and the International Association of Family Surgery chairperson from Hungary. They come and they participate. And we should realize that so much of the surgery can be done as day surgery. There's no need for patients to be kept overnight. I think we have to move forward in this area. And this is my team as compared to Dr. Bhatt's team. And this team, Dr. Jaypriya is a very good surgeon. Half the cases she does, and she's trained by Dr. Mishra. And we take pride in saying that. Thank you so much for your patience here.
Thank you, Dr. Radhakrishna.
Can you go back to the street for a minute?
Their own patients so fast. Any queries from the participants? Yeah, sure. Somebody can do.
Explain about she is the one who got those awards. She also presented in Budapest or series. And tab block has been there for ages, but people don't try to use it much. Actually, the morning case which you have done in the morning, sir, if you run tab block, patient will be walking back home now.
How can you choose these patients?
No, actually, I got shown in one of the earlier slides.
Selection.
Yeah. I'll just make sure that these patients' liver function tests are normal, no suggestion of any biliary stones. First criteria. Second criteria, they should be ASA 1 or 2, not more than that. They should have a cardiac issue. They shouldn't have any pulmonary issue because we don't have backup for the patient to stay back in the hospital. They shouldn't have coagulopathy, and they also shouldn't have hypothyroidism. Our anesthetist sees the patient along with us on the day when we see in the morning, by afternoon, investigations are done. The anesthetist says this patient is fit and this patient is not fit. Again, when we presented this in Hungary, one Indian anesthetist from Norway said, why should an anesthetist see now? You know how we do? We telephonically will talk to them. Aren't you a surgeon? Can't you make out this patient is a risky patient or not? Why do you need to see an anesthetist once? Anesthetist will see on the day of surgery because the patient has all the investigations. If there is anything unusual, the surgeon will know it's unusual. The majority of these patients, the anesthetist sees the morning of surgery. So we decide if the patient is fit or not fit.
Dr. Radhakrishna, if I may ask, when do you admit the patient?
Till 12 o'clock in the night. After 12 o'clock, nothing. You wake up at 5 in the morning, take a shower, 5:30 you should be sent. Because these patients will not know where the center is, they'll come to the Apollo main hospital. There's a vehicle will pick them up. We have the telephone numbers. The driver will call them, pick them up, 5:30, 6 o'clock they're in the hospital, 6 o'clock we are there. 6 o'clock we start.
I think that is one place where the H's would come in. I'm sure your hospital is very efficient. A few hours to... I agree.
There are two things I'll mention here. When one of my friends from Gurgaon, she came to Chennai recently and said, block is not done. You people are not just surgeons that don't bother about pain. Patient is pain. That's not of your concern at all. Pain is our concern. A little bit pain is okay. And patient asks, no, how do you think you can undergo surgery without pain? Is what we ask generally. We ignore pain to a great extent. When it's possible to make it absolutely painless, it's possible, we don't do it. That is the first mindset. Second mindset is, one of my seniors says, Radhakrishna, only you do, I can also do, but I don't want to get up at 5 o'clock. I don't want to get up at 5 o'clock. What is the need? Okay, I think we have to progress. We've been doing laparoscopic gallbladder surgery for dogs years. I've been moving forward. I make anything better. I think we should.
I think another reason why daycare surgery is there the insurance pays, and insurance counts the number of days in the hospital. Here probably the cost is not increased if the patient stays in night extra. So we are not so much bothered. Patient mindset, like you said, if you tell the patient you're going to be going home in the afternoon, he's ready for that. If you tell the patient is going to be here 2 days, then he is planning accordingly, mindset wise. So if the insurance is paying and they're counting the number of days, then probably we'll also be pushing towards daycare surgery and cutting down the cost to a certain extent. That's where it got a push in the West.
That's right.
Not really from the surgeons or the anesthetic side.
A number of insurance companies now are...
They were actually a hindrance till now. They wanted overnight stay and you couldn't put them into it. Yeah.
It's a big
Very
another advantage also,
Yes.
like we have, mobile cams for the hands, for taking to the patient doorstep maybe. So then we can, deliver the advantage of laparoscopic surgery to the upper remote areas. I think that can also be very, very much possible.
What we need to say is most of the laparoscopic surgeries, patient has to remember whatever the surgery might.
I totally agree with that.
Anyone else?
There is one question from the audience.
From Dr. Dhingra.
This is not tap lock completely. Tap lock is to get to the plane. I think the critical transfer abdomen is the internal obliques is where the nerves come. Under vision, under ultrasound guided, they go just to that level and inject about 20 cc in 4 places. And that will completely block it. That's being given for cesarean section and so many other surgeries now. Important thing in these tap blocks, and most important thing in post-operative anesthesia in these patients, when they wake up, they have no pain, they are not having pain. When they wake up, they have pain, they'll continue to have pain. So that is the secret of this. But we inject intravenously, we give blocks, and we also give rectal suppositories, and we completely block all the 3 pathways for analgesia. And when they wake up, absolutely no pain, and they're just cheerful. You have to see to believe.
I think there is a vicious cycle to the pain. There is a pain, patient moves more pain, and then we move on to